for about 10 years, and he's been fairly stable on Cinemet, 125 milligrams 4 times a day. He was seen a few months ago in clinic, let's say, and he was doing quite well. But suddenly he's been admitted with pneumonia, and while on the ward, his Parkinson's control has become very bad. He's having episodes of severe slowness, bradykinesia, episodes of dyskinesia where he's overtreated, and it's all, his Parkinson's has gone to pot. So how are we going to manage this chap? Good. So people are talking about getting the medication on time. Yeah, so that's first thing to make sure, checking compliance. This is quite a common scenario that you see on the ward. And basically, the thing that I'm trying to get across here is that Parkinson's disease goes bad with any intercurrent illness. It doesn't matter whether it's some kind of infection like pneumonia, whether it's, if someone that's had surgery, whatever it is, Parkinson's just goes all over the place with an intercurrent illness. And changing the Parkinson's treatment doesn't usually help that much. He's having off periods, so you might want to increase stuff, but he's having dyskinesia periods, so you might want to decrease stuff. You can fiddle about with the medication timing until you drive yourself crazy, but you're probably not going to make any difference here. So really, we're just going to treat the medical condition, and the Parkinson's will kind of slowly improve over time, although it can take quite a few weeks, even months after treatment or after making the Parkinson's better before the sort of. So it can take a few months after making pneumonia better or the medical condition better before the Parkinson's treatment, the Parkinson's symptoms kind of stabilize. And if you really have to, you can fiddle with the Parkinson's treatment, but remember to kind of unfiddle it when, or hopefully if and when the patient becomes better. So it's just worth kind of knowing that when someone's got an intercurrent illness and they've got Parkinson's, the PD just goes all over the place, and there's nothing you can do about it really, apart from trying to control the medical problem, and then usually the Parkinson's will improve as well. Any questions about that one before I go on to the last case? I don't think so. Okay, last chap, 74-year-old chap, diagnosed with Parkinson's 10 years ago. He's been doing quite well on Cinemet. He's on a 187.5 milligrams 4 times a day. He's also on Ropinirole prolonged release 8 milligrams daily. And in retrospect, he's had some cognitive issues, kind of memory problems and visual problems over the last year or so. But he's suddenly been admitted with acute confusion and visual hallucinations. Yeah, and you're asked to see him on the ward. So what do we think is going on here? Or how are we going to manage this chap? One person so far in the chat. Somebody's put delirious. Someone's put low body dementia. Waiting for acute delirium. So yeah, so this is possible to think of. So a lot of people are talking about delirium here. So the diagnosis here is probable Parkinson's disease dementia. Parkinson's disease dementia, when we use the word dementia, we basically mean a progressive deterioration in cognitive function sufficient to impair the activities of daily living. And so if someone's got mild cognitive impairment and they're still able to do all their usual activities, then they don't have dementia. But if it's affecting their activities of daily living, then that's when we use that terminology. And Parkinson's disease, when you've got Parkinson's disease, you're at high risk of dementia. And Parkinson's disease dementia is similar to Alzheimer's disease in the terms of it causing this progressive deterioration in cognitive function sufficient to impair activities of daily living. But there's three big differences between Parkinson's disease dementia and Alzheimer's. The first, of course, is the Parkinson's. It's quite rare to get Parkinsonian features in Alzheimer's disease, and that's a very, very advanced, rigidity, tremor, bradykinesia. But it's obviously a feature of Parkinson's dementia. The second thing is that people with Parkinson's dementia often have frank visual hallucinations. That's quite rare. in other scenarios. But frank visual hallucination is a very common feature in Parkinson's dementia. So when you see anybody in the ward, any elderly person who's got visual hallucinations, you should be thinking about Parkinson's dementia. And the third and the key thing here, and the reason that I've presented this case, is that it's actually quite common in Parkinson's dementia to have acute confusional episodes. So the story is somebody's got mild cognitive symptoms, but they're batting along quite well, and all of a sudden they become really, really confused, and they really confused, and they get admitted to MAU. And of course, when you go to EAU or MAU or any medical place, then everyone that's confused has got a UTI. That's just a diagnosis that they always get. And so they go on to trimethoprim or whatever. And then over the next week or two, the confusion gets better, and the patient kind of goes home, and everyone thinks, okay, we did something good there. But we talked there about visual hallucinations being very common in Parkinson's. And then, a week or two later, the MSU comes back, or a little while later, and you find actually there was nothing in it. And it's important that this is the kind of key point, that this kind of acute confusional episode where they get acute confusion lasting for a week or two and then it gets better is actually simply a feature of Parkinson's disease dementia. It's what happens. It's a kind of, obviously you've got to exclude infection. Obviously you've got to look for UTIs and stuff like that, but it is just a feature of the condition that you get these acute confusional episodes. And we see it all the time. I've got patients that have been admitted with 20 UTIs over the last 2 or 3 years. They go to see urology, they have bladder surgery, all this type of stuff, and they probably never have a UTI at all. It's probably all been acute confusion secondary to their PD dementia. So it's just worth knowing that it just does that. You don't need to look for a reason. People have talked about overdosing on medications, UTIs, constipation. Obviously, you look for all that stuff, but more often than not, it is simply a feature of the condition itself. And I think it's important to just be aware that that's how it behaves. People are asking about Lewy body dementia, Parkinson's disease dementia. Basically all the same thing. If you're going to be technical about it, if you develop dementia within the first year of the onset of the Parkinsonian symptoms, then we use the term cortical Lewy body disease or Lewy body dementia. Whereas if you develop dementia more than a year after the onset of Parkinsonian mobility problems, then we call it Parkinson's disease dementia. So it could be 364 days versus 365 days, and you change the name of what you're dealing with. So really, just think of them as the same thing. And treatment of Parkinson's dementia is a bit of a balancing act, because the drugs that we use to make the mobility better make the confusion worse. And so you've got to kind of get your balance right. And normally you prefer them to be a little bit less mobile rather than very confused. And so in terms of management, we talked about excluding infection, but UTI is very much overdiagnosed in this type of scenario. You want to the least likely drug to cause confusion is levodopa. Things like dopamine agonists and amantadine and all that are much more likely to cause confusion. So slowly withdraw everything until they're on levodopa monotherapy, and then you might want to reduce the levodopa dose as well. This will probably worsen Parkinson's symptoms, but you maybe just need to accept that they might be a bit slower, but at least they're not confused. Try and keep them in a fairly light room, because they're very prone to misinterpreting shadows and things like that. Minimal disruptions. Don't check their blood pressure 20 times a day unless they really need that, because they get quite paranoid, and that can be problematic. You've got to avoid atypical antipsychotics, which block dopamine receptors, dopamine BD2 receptors, like haloperidol. We can use quetiapine sometimes. That's an atypical antipsychotic, which at least at lowish doses of 75 milligrams per day or less doesn't massively worsen Parkinson's disease. Occasionally we use clozapine in this scenario, because that doesn't worsen Parkinson's at all, but there's other issues with that. You need blood monitoring and so on. You can use ribostigmine, you can use benzodiazepines as well, or other options that we can use in this scenario. So any questions about that? Do you have to review and reinitiate other PD meds previously withdrawn once past the confusion episode? Somebody's asked. Probably not. I think if someone's had an episode like this they're likely to have it again. So I would just manage them on levodopa monotherapy. I wouldn't put them back on things like agonists and stuff in this scenario, because the likelihood is that this confusion thing would happen again. How should we increase levodopa dose in hospital patients with worsening PD? Uh, I don't quite understand the question. How should we increase levodopa dose in hospital for patients with worsening PD? I tend to increase in steps of, let's say, 62.5. Are you talking about somebody with dementia or just generally speaking? If it's somebody just generally speaking, I would normally start on 62.5 TDS, go up to 125 TDS, then maybe go up to 125 QDS, and then there's two scenarios that you might be dealing with after that. You might be dealing with somebody who's just never responding that well, in which case I might go from 125 QDS to 187.5 QDS, which is 1.5 tablets rather than one. Whereas if they are responding well, but they are wearing off before the next dose is due, then I might go from 4 times a day to 5 times a day, but keep the dose the same. Or I might add in other drugs like entacapone or picapone, rasagiline to try and reduce make the levodopa and dopamine last a bit longer. So it depends on what the actual problem is, what sort of increase that I would make. With the acute confusion in PD dementia, how long a period of confusion would you possibly expect? Is it like in the case of delirium that could last for months? Yes, a bit of both. I mean, it will only last, for a week or two. That would be the most common thing. But it can last forever in some cases, like delirium can. It's probably quite a similar type of process as delirium is. So people don't always get back to baseline, but mostly they do, at least initially. But they can be a very hard group to manage. Any other questions about PD? I think that's probably all we want to say. In patients with dyskinesia, like in the previous example, how would you recommend reducing the dose? Normally I reduce in steps of 62.5 milligrams. So if they are on, let's say, 187.5 milligrams 4 times a day, which is 1.5 of a 125 4 times a day, I might reduce all the doses to 125. So they might go from 187.5 QDS to 125 QDS, something like that. How do we manage if there is a scenario of NMS-like symptoms from missed dose? Um, Basically, just got to give them some levodopa. Uh, like if they're worsening Parkinsonian symptoms, just give them some levodopa. Anything really, 125 milligram tablet. If you don't know what they're on, just give them 125. If you know what they're on, but they're not due a tablet for a while, but they've not had it, then just get something into them basically. Any wire terms like cogwheel rigidity frowned on? We just don't use them anymore. We don't find them that useful, because cogwheel is a little bit of a confusing term. It's kind of rigidity with tremor superimposed, and one person's cogwheel is another person's lead pipe. So I think people don't quite know what these terms mean fully, and so we don't use them anymore. Somebody's asked about management of Parkinson plus syndromes. Um, I think it's difficult to answer that question in a quick soundbite, but generally speaking, the Parkinson plus syndromes like PSP and MSA don't respond well to levodopa. So you're generally speaking looking at symptomatic management, therapy input for speech, gait, MDT input. The drugs don't do a great deal, if anything, for people with atypical Parkinsonian syndromes. Next question. I don't know if people can read this, so I'm reading these out. I don't know if everyone can see the chat. In patients with aspiration pneumonia and PD, do we use NGT for feeding while they are unwell? I don't think I can answer a question about withdrawing feeding and things like that. Uh, I don't think I can answer that as a one size fits all answer. We don't put PEG in Parkinson's very often. So it's quite rare for people with Parkinson's to have quite such bad swelling problems that they need a peg. It does happen, but it's quite rare. It's much more common in the Parkinson plus disorders like PSP and MSA. It's not. I can't think of many times that I have put a peg into a Parkinson's patient, and I look after a lot of them. but certainly with the MSAs and PSPs, is not uncommon. Um, any more questions on Parkinson's, or should we move on? Any particular drug? Okay, I didn't talk about drug-induced Parkinson's. Um, okay, any particular drug that you've noticed to cause drug-induced Parkinsonism? So obviously these psychiatry drugs like haloperidol and all the antipsychotics, but everybody knows that they've got dopamine blocking activities. The ones that people don't realize are the stematols and the maxilons, the ones that are used for stomach problems like nausea. Some GPs put any dizzy person on stematol, and they are dopamine blockers just as much as are things like haloperidol. So, once or twice a year, I see somebody refer to the Parkinson's clinic with possible Parkinson's, and it's just somebody that's on stematol for some reason, often if they're being a bit dizzy or something. So these are the two to be aware of. Somebody's talking about deep brain stimulation. So Parkinson's, this purpose of this talk was more to talk about acute presentations that you might see as a kind of medical person on call. But in terms of managing Parkinson's just in the clinic, in a more, cold case scenario, we think of Parkinson's in three stages. Okay, we have what you might call the honeymoon stage, where they're on medication, and to all intents and purposes, they hardly have any symptoms. You'd barely know that they had Parkinson's, and that's what we call the honeymoon stage. Although some people don't like that term because it's not really a honeymoon when you've got a neurodegenerative disorder. And then after that, they start to have fluctuations where the medication is not covering the whole day. So they take the tablet, they wake up in the morning, they're quite slow, they're quite bradykinetic, they take the medication, it works and they're good for a while, and then they become dyskinetic and they're all over the place with involuntary movements, and then they start to wear off before the next dose is due, and they're very slow again. They take another tablet and they have this bouncing around all day, up and down and up and down, and we call motor fluctuations. And you move the timing of the medication around, but it doesn't make much difference. You get rid of the off period at 10, but then they have an off period at 11 instead. You might use drugs like entacapone and rasagiline to try and smooth things out, but you're struggling because they're just fluctuating up and down. But when they are good, they are good. That's the key point. When they're good, they can walk well. They don't have any of this levodopa resistant axial symptoms that we talked about. So when they're good, but when they're bad, and they're up and down. So that's when we think about things like deep brain stimulation, is to smooth out that fluctuating stage in Parkinson's disease. And then there's a stage 3 where they start to develop a more palliative stage where they start to develop these axial symptoms, like we saw that guy in the video, where they have gait problems that don't respond to anything, don't respond to medication, don't respond to deep brain stimulation due to pedunculopontine nucleus degeneration. They might also get dementia as well. So when they get to stage 3 disease, then DBS is not going to help. So DBS is something that we use for that second fluctuating phase of the disease. And you can actually use it quite early, even when there's been a study looking at quality of life when you take a group of people with fairly mild Parkinson's, but it's just starting to fluctuate, and they randomized half of them to having deep brain stimulation right there and then, even though they were quite mild and they were still holding down jobs and things, but they were fluctuating a bit, so it was annoying to them. And then another group, they randomized to just carry on medical treatment. And the deep brain stimulation group did a lot better when they followed up with regards to quality of life. So, and that's in the New England Journal of Medicine. So it was a high impact publication. And so anybody that's fluctuating is suitable for deep brain stimulation. And I think a lot of people are referring them too late. They're waiting for them to be, wheelchair bound and, like that guy that we saw in the video. And it's too late by then. You actually want them just fluctuating and quite early. And somebody said, how often do you use dopamine pumps and what's the criteria for referral? So when I said that in that stage 2 disease, when they start to fluctuate, that I think deep brain stimulation is an option. Other options there are subcutaneous apomorphine infusion, duodopa, which is an intrajejunal levodopa, and this new treatment, which is subcutaneous levodopa. They're all different options for the same thing, which is fluctuating patients. So we have an MDT where we discuss which patient to give which treatment, but I wouldn't say that we have a definite criteria when you would go for one treatment over another. These are all your options for fluctuating patients. So is that all questions about Parkinson's? I think we're done there. Good. Okay. So, well, I moved straight on to. I was going to do two things, one after the other. So I might just do stop sharing now and then get the videos up. The next prep talk. So I was going to have a break between the two talks, but probably don't have time because we're a little bit late. So I might just go straight into this movement sort of video. Let me just look and see the timetable. So I think it's 3:30 that I have to speak to, maybe a little bit after. So we'll see how we go. So what I'm going to do now is change tact and do a presentation on movement disorder videos. So we've talked about hypokinetic movement disorder, the most common one being Parkinson's disease. These are conditions where you have too little movements, the movement's too slow. But there's also a bunch of conditions where you get hyperkinetic movement disorders, where there's too much movement, involuntary movement that impairs normal movement, if you like. And these are all called these for different names like dystonia, chorea, myoclonus, tics, and so on. And a lot of kind of non-specialists use these terms kind of interchangeably, or they might talk about someone having a dystonic, choreic, myoclonic tic, or just use them all together, or nobody really quite knows when you use one word and when you use the other word. And it's true to say it can be quite difficult, and even movement disorder specialists will argue over what's dystonia, what's chorea, and so on. But it's true to say that there are people that it's difficult, but there are also people that it's very easy and it's very obvious which you're dealing with. And that's actually quite important from the point of view of treatment and so on. So what I'm going to do here is just show you some videos to kind of hopefully at least start to give you an idea about when we use the terms that we use, when we use dystonia, chorea, myoclonus, tics, so that you'll be slightly better at using these terms at the end of the talk. So here's a video of a chap with involuntary movements of his neck. And what I want you to notice is that his head turns to the left and it goes backwards. He keeps doing that. It goes back to the middle and then it goes backwards and it goes to the left. So I was to stop the video.
Try to hold it so that it's looking forward.
If I stop the video now and I said to you what's going to happen, you'll see the head's going to turn left. Oh, the head's going to turn left and the head's going to go backwards. So it started again there. So it keeps going left and it keeps going backwards.
Okay, try to hold it so that it's looking forward, that you're looking forward. Me again.
So the point is that his head does the same thing over and over. So it's a patterned movement. And that's when we use the term dystonia for an involuntary movement, which is patterned. It's the same thing that's over and over again. In this chap, the head was turning to the left and it was going backwards. You could have another chap whose head turns to the right and goes forwards. But in individual person, it's this patterned movement that we see. And so this is dystonia and it affects the neck. And so we call it cervical dystonia. Dystonia can affect other parts of the body, any part of the body, or it can be, we call it focal dystonia, if just one kind of body part's affected, like the neck in this case, or you can have generalized dystonia if the whole body is affected. As far as treatment is concerned, when you're dealing with focal dystonia, we mainly use botulinum toxin injection, which is Botox injected into the muscles, which weaken the muscles. And most people with cervical dystonia can be improved with botulinum toxin injections. We have something in the region of 700 or 800 people coming to our botulinum toxin injection clinic to have these injections done. It doesn't last forever. It lasts for 3 or 4 months and then it wears off and you do it again. They wouldn't keep coming back if it didn't work. So that's cervical dystonia. Next lady's got dystonia as well, but this is the dystonia affecting her eyes and causing her eyes to close all the time. The other name for that is blepharospasm. You can see the eyes closing, so you can barely keep them open. So she's kind of functionally blind because of the dystonia of the eyelids. And again, this is the focal dystonia causing the eyes to close. And we would treat this one with botulinum toxin as well into the muscles around the eye. And usually that can be a pretty effective treatment. This next chap has got a different form of dystonia, what we call a task-specific dystonia, because he doesn't get it any other time apart from when he's writing. And we can see here when he's writing that his index finger extends off the page. So it's a patterned movement because it's the same movement again, index finger extending, and it's task-specific because it's only happening on writing. And it's patterned in him. You could have somebody else who has task-specific dystonia of writing. Some people call this writer's cramp. You could have somebody else where the hand flexes in, but it's patterned for that person. So every time they wrote, it would flex in. I had a patient that was just to give you a little bit of information about task-specific dystonia. What we think happens is that when you're practicing activity such as writing or whatever, that the movements, the muscles that are involved in that movement become, not the muscles, the parts of the brain involved in that movement become strengthened, and that helps you to write better or whatever it is you're practicing. And normally that just makes you better at doing it, better at writing, better at playing a musical instrument, for example. But if you've got task-specific dystonia, what happens is you keep practicing, and this brain area strengthens so much that you start to get all these involuntary movements. So if you're writing, you might your index finger might come off the page, and this is what we call writer's cramp. And it's very common. Most doctors have writer's cramp. I think there's this kind of joke that all doctors have bad handwriting, and of course that's true. At least it is from me anyway. But most of us, certainly of my generation, did loads and loads of writing at medical school. So you're writing all the time. And I find that when I write, my thumb kind of flexes every time I write. I just kind of lose control of the pen a bit. So I don't have crap handwriting as everybody thinks, but I've got task-specific dystonia of writing, or at least that's how I excuse myself. You can get this for other things like musical instruments, people playing piano or violin that are practicing, and they can suddenly get these involuntary movements just affecting whatever it is that they were doing. If we were treating this chap with his task-specific dystonia, we could potentially inject botulinum toxin into the extensor muscles of the finger. It'd be quite difficult, but it could be done. We would cause some weakness, though. You'd probably get away with that because unless he's, a professional subbuteo player or something like that, he's not going to need this kind of flicky outy movement of his wrist, of his index finger very much. But if he had a task-specific dystonia that causes his hand to flex, then if you try to weaken these muscles, you might make the dystonia better, but you're going to mean that they can't, get the top of pickle jars and things like that. So you cause too much disability. So it can be difficult to treat task-specific dystonia. And this next lady, now, we talked about focal dystonia. We saw a video of cervical dystonia. We saw a video of blepharospasm. We saw a video of dystonia of the arm, albeit that was a task-specific dystonia. This next lady has got generalized dystonia. So going through different sounds, her speech is quite strange. She's got dystonia of speech.
Hold your arms out for me now.
And when she puts her arms out, the hands flex down the way. So we call that dystonic posturing.
Point the fingers at each other under the nose now. Yeah, without touching the face or the fingers together.
But most of the signs we'll see on walking. So when she walks, her body arches back and she almost walks on the tips of her toes. So this is dystonic posturing, that she is doing this kind of movement.
And walk to me.
So this is...
Okay, back. Back again. No, forwards.
So this is primary generalized dystonia of the whole body. So if dystonia starts in children, it usually starts as a lower limb dystonia and then progresses to a full body dystonia. Whereas if it starts in adults, it usually is just a focal dystonia and it stays as a focal dystonia. If someone's got generalized dystonia starting in childhood, It can be a primary problem, meaning the brain is normal on scan and everything. There's not been no other issue. Or it can be a secondary problem. So, for example, cerebral palsy is what the most common cause of dystonia. When you see, kids in wheelchairs with these involuntary movements, that's a form of dystonic cerebral palsy. You can get dystonia secondary to various different kind of neurometabolic disorders. A lot of these kind of metabolic disorders, and even PIC and Gauchers and all that can cause dystonia. This chap in the video has got dystonic cerebral palsy.
Okay. Just have you there for a moment. Do you want to count up to 10 for us, Tom?
1.
So especially when he do stuff, when he speak or when he start doing actions, you can see his arms are kind of stretching behind his back. He's kind of fighting against it to try and bring it forwards, but he's got this kind of severe sort of generalized dystonia.
8, 9, 10.
Good. And hold your hand out in front of you, straight out in front of us.
And he's struggling to just get them in the right position, if you like.
That's good.
So it's much more difficult to treat generalized dystonia than to treat focal dystonia. You can't really inject Botox because you'd have to inject over the whole body. If there was an area of the body like most troublesome, you could perhaps inject some Botox into that area. But we're struggling to manage with just Botox. There are medications we can use. Anticholinergic drugs can be helpful, but often we have to use very high doses. Baclofen can be helpful. Tetrabenazine can be helpful. The best treatment, though, is deep brain stimulation. We use, in Parkinson's, I don't think I said it before, but we use subthalamic nucleus deep brain stimulation. In dystonia, it's globus pallidus deep brain stimulation, so it's a different target usually. And for primary generalized dystonia, that's dystonia in the absence of any brain damage, so no cerebral palsy, nothing like that. Deep brain stimulation is fantastically good response. People can have 70, 80% benefit. Primary generalized dystonia is usually genetic. If it's not due to things like cerebral palsy and that type of thing, there's various genes that they've identified. But when you're dealing with dystonic cerebral palsy, the benefit from deep brain stimulation is very modest. Most people don't do it very often because it's quite major surgery for a fairly modest benefit. This chap in the video has got dystonic cerebral palsy. He's actually had deep brain stimulation. He was very keen. He came to us like with all sorts of newspaper articles and things like that, saying that he wanted to have this treatment. So we said, it's going to give you a modest benefit at best, 20% benefit, but he was very keen. So we did that with him and he actually did quite well, not cured by any means, but his dystonia was a lot better. And then he had a scenario where he was admitted to A&E with sudden worsening of his dystonia. And it turned out his deep brain stimulator battery had run out. And so it clearly was giving him some benefit, but not as good. The people that we've done with primary generalized dystonia, they can be almost cured with deep brain stimulation, certainly a lot better.
Okay.
So in this next video, let's have a look at the movement disorder we see in the video. And what we see, let me just get it start playing. This girl has involuntary movements. I worked in Toronto for a while, which is why a lot of these videos are Canadian videos. You can see these involuntary movements that this girl has. Initially, you might think she's a bit twitchy, but there's nothing actually wrong with her. But you'll realize over time that there's involuntary movements, and we don't know what's going to happen next. The point is, it's completely random, these involuntary movements. Unlike in dystonia, there's no pattern. I know her right leg's going to kick out in a moment, and we saw it do that there, but you wouldn't know that. If you stop the video, you have no idea what movement's going to happen next. So it's just completely random involuntary movements. When she's writing here, and you can see how much she's struggling to write and all these involuntary movements that she's get with writing. So before, if you thought maybe she's just a bit fidgety, now you can see that it's more than that, and she's got these involuntary movements, but they're completely random. There's no pattern to them. You don't know what's going to happen next. So that's when we use the term chorea. When involuntary movements are completely random, then we use the term chorea. So I'm just getting my... And lots of different causes for chorea. We show some more videos to go through some of them. The girl that we saw in the video that we just seen, she's got a rare condition called Sydenham's chorea, which is a rare thing that none of you will ever see. So I wouldn't worry too much about that one. It's a post-streptococcal thing that you can get in kids. You don't get it in adults really, and it's very, very, very rare in the UK. It's something that you kind of don't really see much in this country. This chap, and we're talking about the guy on the right, has got chorea as well. He's got these involuntary movements, but they're fairly random, and his involuntary movements are due to Huntington's disease. In the past, it was called Huntington's chorea, but we call it Huntington's disease now, genetic cause. And in his case, his Huntington's was causing chorea form movements, whereas you can also get dystonic movements in Huntington's as well. This chap in the video has got levodopa-induced dyskinesia, so he's got Parkinson's, and he is on levodopa, and he's on a bit too much at the time of this video, and he's got these involuntary movements which are quite random, they're not patterned, so this is chorea. You can get a dystonia as a form of levodopa-induced dyskinesia, or you can get chorea. So you can get both of these type of movements of levodopa. Somebody's asked if chorea continue in sleep. Normally chorea settles down in sleep. Normally it doesn't actually continue while they are asleep. So that's chorea. Another thing to be aware of is that there are quite a few medical causes for chorea. So you can sometimes see this on medical wards. The sort of things to think about are polycythemia of any cause can cause chorea, hyperglycemia. There's a thing called diabetic steatopathy that you get with very high glucose levels. And so hyperglycemia can cause chorea. Hyperthyroidism can cause chorea. You can get it in lupus and cardiolipin syndrome. So there's a few kind of medical causes for chorea to be aware about. Anticholinergic medication can cause chorea as well. So you get that in sort of drugs like amitriptyline, which have got anticholinergic actions. That can cause chorea. So, you know, looking at the blood tests and looking at the drug chart is the first thing that I do when I'm faced with some of the chorea before I start thinking about, you know, rare kind of neurodegenerative disorders and so on. Okie dokie. So we're still stop tour through movement disorders. Let's look at this next movement in the video here. So what I want you to look for is these tiny little, very, very brief movements that she has. See that left hand brief movement?
Like we showed you like that.
Really quick movements. If you were to do an EMG, and we sometimes do, and record these movements, you'd find that they were less than 100 milliseconds. So very short. If you tried to move your hand as quick as you could in a quick jerk, you'd do like 600-700 milliseconds as best you could do. So these are much shorter than that. So they're very, very brief involuntary movements. And when you get involuntary movements that are brief, that's when we use the term myoclonus. So myoclonic movements are very brief. You can get positive movements, positive myoclonus. That's just a sudden jerk of movement. Or you can get negative myoclonus, which is where you've got an ongoing movement and you suddenly lose that, like a flap that you might get. I don't know if you can see what I'm doing here or not, but like if you've got liver failure, or renal failure, or respiratory failure, and you get this kind of flap, that's a form of a negative myoclonus. And there's lots of causes for myoclonus, lots of medical causes that we just talked, like, you know, liver failure, renal failure, respiratory failure, and various different kind of degenerative and genetic diseases as well. The girl that we saw, the previous lady we saw, and this lady have got the same condition. So this girl has got little jerks of her head that you can see.
Good. Can you do this for me? Wide open. Quick, 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 quick.
See that jerk of the head there? And it's quite often when you get people to write, you can see these movements quite well. Just little jerks of the head there. She's got brief myoclonus, and if you see her walking here and also running, you'll see her left leg has got this kind of funny posture. It's kind of going out the way. It's a patterned movement. It's doing the same thing. It's going out the way. So she's got dystonia and she's got myoclonus. Does anybody know what condition this is? It's a genetic condition. Does anybody know what it's called? Or what would you call it if you just discovered this condition and it had dystonia and it had myoclonus? What might you call it? Any guesses? Somebody says dystonic myoclonus, dystonia myoclonus disorder. Good. Yeah, so the third person's got it right. So you've got to get it the right way around. So it's myoclonus dystonia, not myoclonic dystonia, if I'm going to be pedantic, but myoclonus dystonia is a genetic condition where they get myoclonus and dystonia. We've got quite a few patients with this in my clinic, that lady that we saw there. It's usually due to a mutation in a gene called epsilon sarcoglycans. There's an interesting thing about the genetics of this condition. Interesting, and genetics are not words that normally appear in the same sentence, but you actually, although the gene, you inherit this gene from your mother and from your father, but you don't use your mother's gene. You imprint it. You just kind of, I don't exactly know what that means, but you kind of just shove it away to the side in the nucleus, and you don't use it when you use your father's gene instead. And so if you only inherit this condition from your father, so girls can have the condition, but they don't pass it on. What they do, they can pass the gene on, but they don't pass the condition on. But but you only, not always, but you very rarely get the gene passed from the mother. You only really get it from the father, which is the opposite of things like mitochondrial disease and so on. And it causes myoclonus and it causes dystonia, but myoclonus is much more so than dystonia. Really, the only thing traditionally that would help the myoclonus is alcohol. Alcohol makes them a lot better, and so a lot of them become alcoholics. We're increasingly using deep brain stimulation now to treat myoclonus dystonia, and it's globus pallidus DBS as well, and they generally do fairly well. So we're learning some terminology now. We're getting towards the end, hopefully, because we don't have a great deal of time. What do people think about this video here? What are we seeing in this lady?
Close your eyes. Keep them up. Your feet on the ground. Let's see you tap your toes. If you can. Now the right side. Just try to take a couple of steps to Dr.
I
Kern.
think I have to be beside the desk.
Here.
Or an arm on
Yeah,
both sides.
I've got both of you. Okay, now try to get stability on your feet. Can you just balance on your feet there?
Nope, my knee's going.
That's just no problems.
So we just in terms of the wordage, so we talked about the phenomenology, we talked about dystonia, we talked about chorea, we talked about myoclonus. What words do you want to use to describe this? What of all the people we've seen up till now, who does she look like? So people are putting dystonia. I think most people saying that. Hemidystonia, some put. So I think most people are thinking this looks like dystonia, and I would agree. She's got this patterned movement. It's maybe a bit asymmetrical, but the whole body is affected. Her legs, as we saw right at the beginning of the video, we're not going to show the whole video. You see the legs are in that dystonic posturing. They're kind of pushed out like that. And when she walks, she really struggles to walk. So this lady has got generalized dystonia. She looks quite like, from a phenotype, quite like the lady we saw with primary generalized dystonia towards the beginning. She's had this since childhood, and she's been diagnosed as having dystonic cerebral palsy. But there's one other condition that you need to at least think about before you rush into a diagnosis of dystonic cerebral palsy. Does anybody know what that is? It might be something that people generally don't know about, but that's the kind of point of presenting this. So let's look at this lady. Someone said Wilson's, not actually thinking about that one, but it's on the right sort of lines. This is this lady after one tablet of levodopa cinemet, 250 milligrams, I think it was, that we gave her. It could have been 125. And she's completely fine. You just look at the posture of her legs, they've gone away. That involuntary movement's gone away. The legs are in a normal posture now. Remember, this lady's been in a wheelchair for 30 years, so she's not going to be able to, she's had various different unnecessary orthopedic procedures, and so she can't walk perfectly, but she's massively better than what she was.
No, I'm talking to her.
Oh,
So this is a condition called dopa responsive dystonia. So someone's put about the weird one from Awakenings. That was post-encephalitic Parkinson's. It's a different thing, but I suppose in some ways similar. This is a condition called dopa responsive dystonia. It's not actually Parkinson's. It's a genetic condition where you lack one of the enzymes involved in making dopamine. There's a few genetic causes, but the most common one is a gene called GTP cyclohydrolase 1. And these people get diagnosed as having, somebody's calling me. These people get diagnosed as having, hold on a sec, my phone just went, get it back. Sorry, I'm just trying to get back on my on the chat so I can see what's happening on the chat. Yeah, these people get diagnosed as having dystonic cerebral palsy because they present, as childhood with generalized dystonia affecting initially the lower limbs. And it can look very like cerebral palsy. And then, if they don't get levodopa, they go through the whole life in a wheelchair. I've got maybe 10 people with this condition in my clinic, so it's rare, but it's not that rare. We do see it. I've been crash fleet to the ward for somebody who was given levodopa, having been in a wheelchair, for many, many years, and suddenly got up and walked. They just couldn't believe the response. So there are almost certainly people going around in wheelchairs in Manchester who, if they could just have a bit of levodopa, would be able to get up and walk. I think the pediatric neurologists now are pretty onto this, and they don't really miss it. But there are probably, I've seen a few people with this condition. So just be aware, if you see someone with dystonic cerebral palsy, just the first question to ask is, have they had a trial of levodopa? You just give them all a trial, 125 milligrams 3 times a day. So I would give 62.5 3 times a day for 2 weeks, and 125 3 times a day after that. The same as what I give when I'm starting for Parkinson's. If they haven't dramatically responded, they don't have dopa responsive dystonia. It's rare, but it's just something that you should know about, because you can see what a dramatic response you can get. So what about this here? So what movement are we looking at now? We've talked about all the words: dystonia, chorea, myoclonus. What do we think's going on here? Somebody says, how long a trial? As I said, I think I've answered that. So various different words people are suggesting. People are saying myoclonus. I think it's not quite quick enough to be myoclonus, but you could do an EMG to make sure. Maybe it looks a bit dystonia-like. It's too fast. It's too slow to be myoclonus, I would say, because myoclonus is very, very brief. Let's have a look at the video. Are you guys getting sound? That video didn't have sound, but the other videos that have had sound, is the sound coming through to you guys? Yeah, good. Okay. So I'm going to show you the video again with sound.
Work it like that, I want to keep flexing it.
And now turn and face the sink a little bit. Okay.
I don't think there's any real pattern to whether it's foot, face, or leg or what, but there's always one of them that I want to.
Now the shoulder movement that you've got, is that a voluntary thing or an involuntary thing?
No, I'm doing it.
You're doing that on purpose to respond to a need to do it, eh?
That's right, yeah.
So this is a tick, and the reason it's a tick is because they are doing it. It's a voluntary movement that they're doing on purpose. A tick is a bit like an itch that you can't scratch. They have this urge, this kind of uncomfortable sensation, and they need to make the movement. Believe it or not, this kind of rotatory shoulder movement is something that you can learn to do with practice. And a tick can affect any part of the body. You can blinking or throat clearing or moving the arm the shoulder like we saw there. And it can look dystonic, it can look myoclonic, it can look like chorea sometimes. So the way we distinguish it from these other things is to take a history, and we find out that these are voluntary movements that are being made in response to a kind of itch that they can't scratch, a desire to make the movement. And when they make it, they feel a bit better for a while, and then it kind of settles down again, and then it comes back again. Tics are very common. 5% of the population in childhood have in schools and things have tics. Generally settles down as you get older, but not always. And if it's very severe, then it's called Tourette syndrome. A lot of people sort of think of Tourette syndrome with always swearing and stuff, but actually things like swearing is not necessarily. Most people with Tourette syndrome don't do that. Here's a video of somebody with Tourette syndrome.
For teachers, you know, the word is magnitude. The word is magnitude. You know, I will repeat it.
So various types of movement you can get, but you can usually get a diagnosis from the history. So I think we've run out of time, so I'm going to skip tremor.
Can you tell me?
And just to summarize what we have said, so dystonia is patterned, chorea is random, myoclonus is brief, and tics are diagnosed by listening to the history. These are the main take-home messages. I'm not expecting you to be experts in hyperkinetic movement disorders, but at least have a bit more of an idea about where we get these terminologies from. So just to show a last video, this is a video in one of the movement disorder journals. I'm going to show the video first and then give you a kind of multi-choice question to decide what movement disorder we were looking at. So what do we think here? Some people are saying tics. I think most people are saying tics, so potentially Tourette syndrome. I suppose the question you might ask is, why is he doing this kind of, you know, sign like that? Why is he not going fuck or something like that? And the reason is that, well, here's your kind of multi-choice. But this chap is, as far as I'm aware, the only kind of reported case of sign language tics in a deaf and dumb person with Tourette syndrome. So the reason that he's not kind of going fuck is because he can't, and so he does these kind of movements instead. And I think that's all I want to say about hyperkinetic movement disorders. I don't know if we've got any questions. We kind of run out of time at the end, so I skipped tremor. But any questions about that? Are hemifacial spasm and ocular gyrate crisis examples of focal dystonia? So hemifacial spasm, I didn't show you a video of that. I do have videos of that. I wonder if I could show you one. Seeing someone's asked, I think this is a hemifacial spasm video. Hemifacial spasm is when you get a blood vessel close to the facial nerve, and that causes the nerve to be irritable, and the nerve kind of fires off, and you get this twitching. It's exactly the same situation with trigeminal neuralgia. When there's a blood vessel close to the trigeminal nerve, it causes the trigeminal nerve to be irritable, and that fires off, causing these severe spasms of pain. Whereas in hemifacial spasm, it's the facial nerve. So we see this here. See these just little twitches of the right side of her face. So that's hemifacial spasm. See how it's only on one side. Blepharospasm is always bilateral. Hemifacial spasm is always unilateral. So this is just these little twitches you can see. So that's hemifacial spasm. How do we treat that? We can give Botox into the face to help. We do a lot of that. Drugs like carbamazepine can sometimes help, but they're usually, you know, cause side effects and so on. And occasionally you can use microvascular decompression, where you basically separate the blood vessel and the nerve. But it's quite a big operation to do on someone with this level of symptoms. Ocular gyrate crisis is a different thing. It's a form of dystonia, but it involves the eye movements going up, and often you can get it as an acute dystonic reaction to dopamine blockers, and there's various kind of sort of metabolic disorders of children that you can get that as well. Is restless leg syndrome an example of tic disorder? No, I can see why you're getting at in terms of the urge and all that, but no, it's not. It's not. We don't categorize it in the same place as tic. Although I can see why you're asking the question, because there is an urge and so on, but it's a different thing. Hemibalism is chorea, but more proximal down one side of the body. I might have a video of that. I've got lots of videos here, but I didn't show them all. Let me show you hemibalism. So, seeing somebody has asked for it. Where are we? I think I've got a video of that in this lot. Maybe not. Can't find hemibalism. I've got hemibalism video, but I can't find it here now. But it is like why can't I see it? No, it's not in this talk. Sorry, I don't have to come back out of that. I don't have a video of that one, but it's basically just severe chorea down one side of the body. classically due to infarct or other lesion in the contralateral subthalamic nucleus, but it can be caused by lesions in quite a lot of different parts of the basal ganglia. Any other questions? Good, I think that's us. Oh, any movement disorder that you find is most mistaken or misdiagnosed. I suppose functional movement disorders are something to be aware of. I haven't really gone into that because it gets a bit complicated, but they can be functional as well. And that, like, there are ways and means of distinguishing between functional and non-functional movement disorder, but it's quite difficult to kind of, it's more of an, advanced thing. But I don't think a specific answer to that question, that is something that people get wrong specifically. I think it's just a general usage of the wrong terminology sometimes. Even we get the, argue about what the terminology is. Good, I think we should stop there because we've got a break and then somebody else, I don't know who's on next. So I might, who is it now? It's Venetia's coming on at 3:45, so that's quite soon. So I don't know whether you want some kind of break for 5 minutes before that. Is anybody here? I don't know what. Dan, are you here? Do I just sign off?
So we did plan in a quick comfort break. So if you all just want to nip and get a drink, or if anyone wants to nip to the toilet, just you've got 5 minutes now to quickly nip and go.
Cool. Is Venetia here?
Yeah.
She's the
Yeah.
Yeah, she's here. Great.
Yeah.
Okay.
Hi.
Cool. I will. Hi, Venetia. Right. I'm going to leave now. Cheers.
Cheers, Monty. I'm gonna post the feedback links in the chat again for everyone. So I've put all three in there just so if anybody's missed any earlier ones, you can fill them out. Just whilst we're taking this quick break, and then Venetia can start the final session when everybody's back at about 1:45. There you go. Manisha, you can start whenever you're ready now. People will probably start filtering back in shortly.
Oh, perfect. Thank you. Okay, so good afternoon, everybody. My name is Dr. Chauhan. I'm one of the neurology consultants at Salford Royal Hospital. And this afternoon, I'm going to talk about seizures and seizure disorders. I do apologise. I'm just recovering from the flu, so my voice is still a bit croaky. So just bear with me as the talk goes on. Okay, so I've got no disclosures. So disorders of consciousness. So basically, this largely is a clinical diagnosis. Okay, so how we're going to get to a diagnosis is going to be based on what you see and what you hear. And there's very little in the form of investigations that are going to help you along that journey in most instances. So 5 things that we're going to really cover today is if you see an episode in front of you, what does that look like and what does that tell you? The history, what clues are you looking for to help you point you into what pathway you think this diagnosis is going to? If you do think it's epilepsy, how do we classify it? And then how do we manage patients who've gone into status? And then is this status and do we manage it as status? Okay, so disorders of consciousness. So this occurs because there's a paroxysmal cerebral dysfunction that has happened, okay? And that could be due to an epileptic cause, or it could be due to a non-epileptic cause. And in the epileptic cause, you've got physiological things that are happening. So for example, it could be a syncopal event, could it be a metabolic event, or could it be a hypoxic event? And then finally, could it be a functional episode? And is that why that person is having that problem? So semiology. Okay, so what does it look like? So I'm going to show you this video. I want you to take your time to look at it. And then I want you to tell me what you think it is. Right. Now, I can't actually see, I've only got one screen up, so just bear with me as I see the chat. Okay, so we've got some people saying it's generalized tonic-clonic seizure. So most people think that's a generalized tonic-clonic seizure there. Okay, I'm not sure if I'm including sound in this. Let me just double check 1 second. Okay, that's better. Right, okay, so most people thought that that was a generalized tonic-clonic seizure. Okay. Okay, let me just go play that again. So I'm just going to play it again, okay, and I'm going to describe it now, okay, so hopefully you can hear a bit of sound with it as well. Okay, so in this patient, we can see that her eyes are closed. We can see that there's predominantly trunkal movements here. They're kind of pelvic, kind of thrusting. They're kind of vibratory in nature. And we can see that she's got this side-to-side movement of the body and now the head. And now she's got some back arching. And it stops. So these are all signs that are actually classical of a functional seizure. Okay, so this was a non-epileptic attack disorder, or a functional seizure is what we're now calling it as. Okay, so we're now going to play this video. I want people to describe what, well, in a moment we'll have a look and see what you say in the chat. the end of that video. Okay, so again, just bear with me whilst I have a look and see what you've said in the chat. Okay, so yeah, we've got more classical of a generalized tonic-clonic seizure, initial tonic phase followed by myoclonic, and then typical posturing. So preceding tonic contraction scene, synchronous rhythm, and then nil abrupt stop. Okay, good. So yeah, so most people have said that that is a generalized tonic-clonic seizure. Good. Okay, fantastic. So that video there was definitely a generalized tonic-clonic seizure, and what we can see and how that differs is everybody has identified that. Yep, there was that epileptic cry that she had first. Okay, so that is when there's tonic posturing of the respiratory muscles, and that's expelling the air forcefully out of their mouth. So that's often why they can get that cry. And then in that tonic posturing, she's gone into a fixed flexion and extension, and then she's going down into an asymmetric posturing. Okay, and we can see that that's she's very tonic at the moment. There's not that much in the way of tonic activity, but as the seizure progresses, she's starting to get more twitchy. We can see that these twitchies are quite small, and then they're slowly getting bigger and bigger. And we can see that they're becoming larger in amplitude, but more further apart. So they're becoming more, they're slowing down. And then it progresses, so it's slowing down, the jerks are still there, but they're getting further and further apart, and then eventually it just stops, okay? But there's this evolution that happens, okay? So this is a generalized tonic-clonic seizure, okay? Now, the reason why that happens, so this is this patient's EEG, so this is her sort of background rhythm here. And what happens is all of a sudden you've got this spike and wave activity that happens bilaterally and builds up across both halves of the brain, left and right. And then we can see that you've got all this movement artifact, and that's because she's gone into that tonic posturing, so it's causing a lot of muscle artifact. And then we can see here that she's got some clonic activity that's building in, and we can see that these are almost like pulses. It becomes more visible towards the end of the screen, so we can see that there are pulses here, but as you go up here, you can see that they're very close together. And this represents each of these pulses are correlated with the jerks that you see in her arms. And so they're very short and close together here, which is the reason why you don't see much movement in her arms, but as they get further and further apart, they become more and more pronounced. And again here, this is when she's slowing down. You can see these bigger jerks because these waves of spike wave activity are becoming further and further apart. And then it slows down. You've got this post-ictal slowing. Apologies. And so what we can see there as well in that video is that she's got contractions, followed by relaxation. Okay, so you will see a lot of jerking followed by relaxation activity, and that's important when we come to the next video. So have a look at this video and tell me what you think this is. So, what did people feel? Okay, so I got one vote for functional. Okay, did anyone else want to put anything else up on the chat? Okay, so not classical for generalized tonic-clonic seizure. Myoclonus, it's more like need. Functional, need. Okay, yeah, so more votes there for non-epileptic attack. And I would agree with that, okay? So when we look at this video, what she has is that she's got these vibratory movements, okay? And what we can see is a bidirectional movement. So she's bringing her arm in and out very fast in two directions, okay? Both in the arms and the legs at the same time. And we see it continues throughout the length of the time that's in her seizure, and then suddenly it stops, okay? So there's no evolution like we saw in that generalized tonic-clonic seizure from before. Okay, so it's vibratory in nature, and then it just suddenly stops. Okay, so this is a functional seizure, which is also known as a non-epileptic attack. So if we are to play these side by side, we can see quite clearly the difference in the type of movements that we see in a functional seizure versus a tonic-clonic seizure. So what we can see, then this last one, we can see there's a jerk followed by relaxation. Whereas this one, there's this bidirectional. So I want you to remember this for when you're seeing seizures in practice and the quality of the movements that you're seeing, it'll help you to confidently diagnose whether this is a functional seizure or a generalized tonic-clonic seizure. Okay, so there's no sound to that one. But what do people think about seizure? Oh, I apologise. Okay. Yeah, so this is a non-epileptic attack. Good. So in this video, although there was no sound to that video, we can see that she looks like she's got her eyes open and she looks like she's smiling. So she looks like she's conscious in that event. So anyone who is conscious and they've got generalized shaking, that is a functional seizure. Okay, you do not need to treat that like a generalized tonic-clonic seizure. Good. So just going back to the video that you couldn't see, so I think it was this one. I'll just play it again, but I'll mute it. Just make it bigger. Yeah. So as we can see, these are contractions that this lady is having in her arms, the clonic activity. We can see it's a jerk followed by a relaxation, okay? So they're going in one direction and they're relaxing and then jerking again, okay? So it's a myoclonic jerk followed by relaxation. Well, not myoclonic, clonic activity, which is very different from this seizure over here, which is a very bidirectional, short, vibratory, and the arm is moving in two directions, okay? So what we call bidirectional movement. So these are the differences between the types of movements of a tonic-clonic seizure and a non-epileptic attack seizure. Okay, so if you see this, you can be confident in diagnosing NEAD in this case versus a tonic-clonic seizure in this case. Okay, good. Okay, yeah, so in this video, she had the typical truncal pelvic thrusting and she had the vibratory movements, but importantly, she was alert. So anyone who was alert and shaking is a non-epileptic attack disorder. Okay, so what about this event? Okay. So any guesses for that one? And what do you think that could be? So we've got functional, we've got NEAD, narcolepsy, okay. Okay, so no one's really put a generalized tonic-clonic seizure, which is good. Okay, so yeah, so in this event, this person just seems to slump, okay? So he doesn't seem to be doing very much else. Or he swoons, okay? So a minute ago, he was awake, and then he just suddenly slumps to one side, okay? So the only thing that if you didn't have the EEG there with you, you might want to take a blood pressure just to make sure that this wasn't a syncopal event, okay? But we don't need that because we've got an EEG on this gentleman. And we can see that his brain activity is completely normal, okay? So this is a type of functional seizure. And it's not uncommon for patients with functional seizures just to have slumping events or collapsing episodes. What about this event? Okay, so what did people think of that one? Yes, so it is a commonly watched video, so syncope with hypnic jerks. Very good. Okay. So as we can see, in people who faint, they can have myoclonic jerks associated with it. So they can be a jerky event. So often people can confuse that and they will say that they've had a generalized tonic-clonic seizure, okay? So in that scenario, the history is really important that you don't get sidetracked by what somebody's telling you that they're jerking on the floor. As you can see in that last female's case, she jerked for quite a long time. So the history is very important to help you to differentiate what the cause of that jerking is. So there is a slump, you can got lots of regular asymmetric jerks, and that can be seen in syncope. Okay, what about this one?
Okay, can you go back to your chair? You all right? You know where you are? Okay, boy.
Okay. Okay, so we've got vasovagal syncope from blood. Anybody else? Just the one. Okay, yeah. So that was a vasovagal syncope, secondary to a person having a venesection. Okay, so he had his bloods done, he's gone to stand up afterwards, and then he's gone to sit down, and he's has dropped his blood pressure. Okay, so in that video, someone's mentioned, I'll just take the sound off. Whether he had a bit of automatism. He didn't really have that. He went a bit blank, so his face looked a bit blank. He did change a little bit of color. There was a bit of tonic kind of posturing, and his arms kind of went in a little bit, and then he kind of slumped. So his arms slumped down to the side. And again, like we said, you can see some muscle contractions or clonic activity in fainting spells, so you can see a little bit of movement, but I wouldn't. And these are these little jerks that he's having because of the blood pressure falling, not because that's an automatism. Okay, good, well done. Okay, now what about this video? Okay, so what did you think that was? Okay, we've got generalized myoclonic seizure. We've got a focal seizure. Can't comment on awareness, no one there to check. Focal seizure, right arm. This is automatisms. Any more for any more? Okay, so we'll go back to the video. Just going to take the sound off so you can hear me. So this isn't myoclonus. So even though it is affecting both arms, it isn't a myoclonic. It was very different to the cases that we had before, which were more jerk-like, okay? So I agree with everyone else's mention that these are automatisms, okay? So these are kind of automatic movements that he's making. So we can see that he was moving his arms, then he's got some lip smacking, and he's got this repetitive kind of circular kind of motive thing that he's doing with his hand there together with the bag. You're right, we can't comment on awareness because no one's come in and checked on him, but it's possible that he would be unaware, but we can't focus on it completely. So he's got some oral facial and distal limb automatism, so predominantly of the right upper limb, but there was some of the left arm at the very beginning of the case as well. So these features are classical of a focal seizure, okay? And this will be in keeping specifically with that of a temporal lobe seizure, okay? So these features, if you were to see them in somebody, will help you to point out that this is epileptic, number one, but specifically this is a focal seizure, probably arising from the temporal lobe. Okay, good. So that's, I think, all the videos I have for the moment. Okay, so that's hopefully giving you a better understanding that if somebody was to have an event in front of you, you have a better understanding of whether that's an epileptic or a non-epileptic event, okay? History. The history is still, however, very important because number one, for example, you could have somebody where you don't have the episode happen in front of you, and you're very dependent on what the person or their family/friends tell you, okay? So in syncope, obviously they'll have a typical prodrome, okay? And often it's brief, so the episode of loss of consciousness is short, and when they wake up, they come back round to themselves very quickly, okay? So even if somebody said that you saw them twitching, etc., if they gave you a typical prodrome of my eyes went dim, I went very hot, I went very sweaty, I could feel myself falling to the floor, and then I blacked out, and then when I woke up, I felt well in myself again, then I would still call that as a syncopal event, okay? And I put less on the event of the description because they might be over-interpreting the jerking episode that she had. What about functional seizures? So we looked at the events that we already described, and there's some very classical features that if you see them in the seizure will point you to the fact that these are non-epileptic. The other things are that often they have a high frequency of events, so often they can happen quite onset quite quickly, and they'll have lots of them, multiple in a day or multiple in a week. They often are more likely to be prolonged, so happening for 5, 10 minutes, 30 minutes, etc. And they can happen often in medical situations, so in the waiting room, in the scanner. And they might have other comorbidities. For example, it's not uncommon for them to have a chronic pain syndrome, irritable bowel, to have chronic fibromyalgia, for example. Some of these they will describe as if they come from sleep, but actually, if we did some EEG analysis on them, we can see that they were not actually sleeping at the time, but that they're still awake when these episodes happen. And often in their seizures, like we said before, they don't have like this evolution. It may be start abruptly, stop abruptly, but they can also start and stop. And so it can be this stop, go fashion. And often the movements are very irregular, asynchronous. So we've already mentioned some of them, i.e. the pelvic thrusting, the back arching, and a lot of side-to-side head movements, for example. They can be very emotional. They can cry during the event or they can cry after the event. And sometimes some people do have some level of awareness, i.e. they can hear people or see people, but they can't communicate or respond. And there might be other features in the history that might help you to point to whether this is an epileptic seizure or whether this is a non-epileptic seizure. Okay, so in somebody who's epileptic, often they will volunteer the details. They'll give you quite an extensive amount of information and they'll initiate it themselves. And it's quite easy to get them focused on the seizure description itself. And they're very clear that they want to try and get a precise description of what happens. And so to do that, they try and reconstruct the gaps of the bit where they can't remember. And they're quite happy for us to sort of challenge their sort of conscious level at the time. Like, were you awake? Could you hear this? Could you do that? They wouldn't mind being sort of challenged about some of those aspects of their history. Whereas those with non-epileptic attacks, they often have very sparing details to give you. They'll often say they're absent, they have very hard to get information out of, and you really have to try and sort of dig it out of them, and you've got to really initiate the consultation and try and take dig out the history from them. And they'll often just say, I can't recall anything, or I don't feel anything. And unless you ask them, they might not be able to differentiate in how level of awareness that they had. For example, unless you ask, they won't tell you that they could see people, but they couldn't respond. And so it's really important to try and dig down into these aspects of the history, because it can help you to tease out important information. Sorry. Also, it's not just how they say it, but also about the actual event itself. So often, people who are epileptic, the seizure is something that happens to them. So it comes on them as almost a situation or event that happens to them. Whereas in somebody with non-epileptic attack, they often gone off to another place. They go back, they come back again, they've gone to a different, a different space entirely. So again, that can also, from the history, you can get a lot of the feel of what this type of seizure is. Okay. So you've felt like this is epilepsy. So how do you classify? Goodness, I'm very sorry. So we've got generalized seizures. So we've shown you a couple of videos of that, and we've got focal seizures. Okay, so often their history can help you to identify whether it's something that's just gone into something of a focal onset, or whether this has gone straight into a generalized convulsion. Okay, and that's because a focal seizure can start, I guess, in lots of different regions of the brain, and depending where in the brain it comes from, they might get a number of different symptoms. But in addition to the symptoms that they get in the history, there might be clues that you get from the actual seizure itself that might help you to identify whether it's coming from the temporal lobe, whether it's coming from the frontal lobe, for example. So we've talked about temporal lobe seizures already, and we've seen some of the features that you can see in a temporal lobe seizure. But often some of the information that they might tell you in history. So before my seizure, I might get a sensation of a rise and feeling coming up through my stomach, or I might get this really overwhelming sense of deja vu, and it's like a flood of memories that are coming into my mind. And so often these types of symptoms can give you clues of where it's coming from. And that's very classical for mesial onset temporal lobe seizure, coming from the amygdala or just the medial structures of the temporal lobe. So it doesn't just have to be temporal lobe, although that is by far the most common form of epilepsy. And this is another type of seizure, so I'm going to get you to have a look at this. Okay, so let me just get back the chat group up. Earthquake, okay. Sleep thing. So anyone got a feel of what that type of seizure is? So do we think it's a seizure? Do we think it's a functional seizure? A focal seizure, a functional seizure? Ictal psychosis, okay. Withdrawal. Okay, so we think that this is a seizure. Okay, was he speaking? And we've got some functional episodes there. So I'm just going to take the sound off and play again. Okay, so what he does is he does an axial rotation. We can see that he's got these large amplitude movements of the lower legs. Okay, we don't have the audio anymore, but obviously you could hear that he was vocalizing quite a lot, and there was quite a fearful kind of expression on his face and in his vocalization. Okay, so, and we can see that he was asleep before this happened. And then it kind of stopped, arose quite quickly from sleep, and then it kind of stopped quite quickly as well. So this is a focal seizure, okay, but this is a frontal lobe seizure. So this looks very different from a temporal lobe seizure. Now this is very different to a non-epileptic attack, okay? And the reason being, we said about a lot of the movements from non-epileptic attack from before include things like side-to-side head movements, back arching, side-to-side movement of the body. We can't necessarily see that in here, but we can see that he turns over, he has his axial turning, and he's got these large amplitude movements of the legs. Now, those features are actually very classical of a frontal lobe seizure, okay? And again, this vocalization, he doesn't really say words, but it's like a fearful kind of vocalization that he's making. And often that fear component can again be very classical of a frontal lobe seizure, okay? So these are often coming out of stage 2 of sleep. They're often quite brief, and they can have more than one of these episodes per night, okay? This is something else that is happening here. Okay, so in this one, again, the patient was asleep. You could see that she seemed to have, I'm just going to play it again, but I'm just going to take this sound off. Yeah, so she wakes up from sleep, and we can see that the problem is mostly in that right upper limb. So she appears to have some dystonic posturing of the right arm. So it's bent at the elbow, and we can see that her fingers are sprayed off at sort of slightly different angles. It does seem to be a little bit sort of painful from looking at her face, so she can't seem to move it voluntarily, but she's awake. She was able to press the buzzer to let the nurse know that she's had a seizure. Okay. And then again, it stops and it settles down. And by the nurse comes in, the event is over. So that was another type of frontal lobe seizure, but it wasn't, it was a focal aware seizure because it woke her up from sleep. And this was just a motor activity predominantly of the right upper limb. Okay, so like I said, focal seizures can come in lots of different shapes and sizes. And a lot of them can have different kind of motor manifestations. Okay, so compare those events to this one. If I can find my cursor. There you go. Okay, so what do people feel that event represented? So that last event, so we've got NEAD, bilateral, so it's a quick on and off, there was hip thrusting, a lot of vibration, bidirectional, good, fantastic. Okay, we've got one vote for vocal seizure there, but most of these look like they're voting for NEAD. Okay, good. So, so all those who said NEAD is correct. So that episode was, so I'll just turn it off mute. A non-epileptic attack. So this looked like it came from sleep, a very sudden onset. And we can see that there's bidirectional movements of both the arms, and it seems to be asymmetric. So the right arm's doing a lot more than the left, but the left is kind of on and off. And we can see that the movement changes, so the direction in which the movement is changing. And again, the legs were doing a sort of similar thing. And she seemed to come around very quickly because she was alert enough in order to press the event button. Okay, so this is a generalized body activity that was happening there. So I wouldn't and obviously and with that kind of amount, if this was a generalized tonic-clonic seizure, you would expect that person to take some time to recover. So she wouldn't necessarily have pressed the button immediately afterwards, but clearly this person recovered very quickly. It may be that she was aware during that episode if someone did come to see her at the time of the event. So often they say that it happens from their sleep, but often when we do these patients' EEG, we can see that the background with them is got normal awake patterns, and so they're a kind of pseudo-sleep seizures. But you can see that that pattern was very different from the two other sleep seizures that we can see, so the frontal lobe seizures that we can see in sleep. So it can be quite easy to differentiate non-epileptic attacks from epileptic seizure. Okay, so we're going to go away now from classifying seizure disorders and epilepsy to the management of status epilepticus. Okay, so what is status? So status is a seizure that doesn't self-terminate, but so the definition has evolved over time, and we've now sort of in 2015 ILAE classification has suggested that a seizure is a condition that results from a failure of the mechanisms that are responsible in seizure termination or from the initiation of mechanisms that lead to abnormal prolonged seizures. And we call that time point 1. And then it can have long-term consequences after a time point 2. And that could then long-term consequences include neuronal death, neuronal injury, and alterations of neuronal networks. So this is a little graph. So we can see here that, so this is for a generalized tonic-clonic seizure. If this person goes into status, and there are compensatory mechanisms that are going on in the brain that allows the amount of glucose levels to remain high and the oxygenations to remain high in order to keep up with the amount of brain metabolisms that is needed in order to go through that seizure. But after a certain point, which we think is around 30 minutes, those compensatory mechanisms fail. So we can see that the blood oxygenation, where's my cursor? Here we go, no longer is able to be maintained. And so that cerebral blood flow drops down. The amount of blood glucose that's in the stream is decreasing, and we can't maintain it, so it's continuing to decrease. And then what's happened physically is that we can see a generalized tonic-clonic convulsion, but after a while, because we've used all energy reserves and there's not much energy to continue the myoclonic activity, you get this electromechanical dissociation. So you no longer have any physical manifestations of the generalized tonic-clonic seizure, but the brain itself is still in an electrical convulsive seizure. So that's when we start to call people going into a non-convulsive status epilepticus. Okay, so we think that time point 1, i.e. the time where a seizure is not going to stop by itself and therefore needs extra intervention, to be about 5 minutes. But the time point where we think that permanent damage can occur is from approximately 30 minutes onwards. So obviously we want to be enacting before then to try and prevent that 30-minute sort of neuronal consequences from happening. Okay, so that's why a lot of our status guidelines are based on that sort of time frame. And so again, just reiterating the stages of convulsive status epilepticus. So we've got this early stage where you have myoclonic activity, then you've got a continuous seizure activity for 0 to 5 minutes. And then between 5 and 60 minutes, the motor manifestations become less marked. And then you might not see the motor manifestations at all, so that then they become, they cessate. And you just get this subtle generalized tonic-clonic status epilepticus. So it's something that is going on in the brain, but we can't see it physically. And if they're in this condition for more than 24 hours, then that's new onset refractory status epilepticus. Okay, so how do you manage status? So if someone's having a convulsive seizure, obviously you're going to do your ABC management. Okay, you're going to think about sugar in all patients, because obviously that's a treatable cause for seizure activity. And you're going to review the diagnosis. So we're going to look at the seizure, and you're going to spend at least 30 minutes, because we know that 30 seconds is safe. You know, nothing is going to, no harm is going to come to that patient at the first 30 seconds, to look at the patient and to see what kind of movement that person is having. Okay, and are you confident that's a generalized tonic-clonic seizure? If that is, that's fine. You're going to go down the status epilepticus protocol. But if not, if you're confident, actually, no, these got features classical of a non-epileptic attack disorder, then you're going to go and provide some observation. You're going to, yes, monitor the oxygen saturations, but you want to try and sort of de-escalate everything and make sure that they're in a nice, calm, comfortable position. But obviously, if you have any doubt, then you might need to review the diagnosis, call for help, get an EEG, or call the on-call neurology team. Now, in somebody who's going on to have ongoing epileptic seizures, and obviously lorazepam is your first-line treatment choice. And if it doesn't stop, then again, you're going to use more lorazepam, and then you're going to, if the seizures continuing after about 5 minutes after that, then you're going to go on to your second-line therapy. And obviously, at any point where the seizure stops, you're going to review while that person has gone into a seizure and investigate accordingly. But if their seizure doesn't stop, then you might need to think about going to the intensive care unit and manage as for refractory status epilepticus. So how do we treat status epilepticus? So obviously, there's different ways that you can do it. So if they've got intravenous access, you're going to give lorazepam. If you don't, then you're going to give IM buccal midazolam. Okay, so there's lots of randomized controlled trials that show that benzodiazepines are effective in treatment status epilepticus. So this is a trial which showed that lorazepam compared to phenobarbital, diazepam, or phenytoin was more effective in terminating status epilepticus compared to any of those other types of treatments. And again, this is looking at a number of out-of-hospital status epilepticus that was treated by the paramedics on their route to hospital. If they were given placebo, the proportion of patients who were still in status obviously was much higher compared to diazepam, and then compared to lorazepam, which was shorter and much more effective. Now, when you compared lorazepam to IM midazolam, we found that it was non-inferior to IV lorazepam. And part of the reason for this might be because it's quicker to give IM midazolam. So you don't need to faff around with getting a cannula and getting the vial out and injecting it. You can just immediately inject IM midazolam into an available muscle. Now, one of the problems is that sometimes people seem to be quite cautious about giving benzodiazepines. And so often we find that people don't get the right treatment or sufficient treatment in that first line part. So if we were to audit it, we could see that they're not given sufficient intravenous benzodiazepines. So, for example, this is a study. This is the EZ study, which looked at patients who were in status epilepticus and they didn't respond to first-line benzodiazepines. Now, they looked at that at how benzodiazepines were used, and we could see that in this population, the vast majority of them did not get the full treatment dose at their first dosing. So in this cohort of groups, only 3, so there weren't that many patients, but only 3 patients, actually most of them got 10 milligrams of diazepam. But when you got to buccal midazolam, only 8 patients got 10 milligrams. The rest were underdosed, so they got 5 to 6 was the most commonly used dose. In lorazepam, most people got 2 milligrams of IV lorazepam. Only 10 patients got 4 milligrams of IV lorazepam. So there is a concern that patients doctors will cause problems by giving IV lorazepam, but there's clear evidence that IV lorazepam, when given, can stop or terminate status epilepticus. And therefore, it's very important that we give the full treatment dose, because it might well be that the reason why these patients go into second or third line and status epilepticus management is because they have been inadequately dosed at the beginning. And again, I think most people are concerned about the respiratory compromise. And this is just to remind you that in this population, people who were not treated with a benzodiazepine were twice as likely to have respiratory compromise compared to those who were treated. And so status epilepticus in itself is a dangerous thing. So that's why we need to treat it. And the best form of medication that we have for that is the benzodiazepines. And therefore, we should be given adequate doses at the first point, so 4 milligrams of lorazepam. Okay, so going on to second-line treatment. So again, that EZ study looked at levetiracetam, phenytoin, and valproate, and it found that there was no real difference between these, that they're all very equivalently effective in terminating status epilepticus. And so the options really now that we go for first will be IV levetiracetam. with a maintenance dose of 1.5 milligrams BD, but you can still use sodium valproate, and obviously phenytoin is still there as well. But phenytoin, there are some caveats. You do need to make sure you've got cardiac monitor in there, and you can get extra causation like injuries, etc. So you do need to make sure that you're cautious when you're giving it. And there are a few other second-line options that you can consider. So phenobarbital is an old-school medication, but it can still be used, and it can be very effective. And lacosamide is a new medication, can be given intravenously. And again, studies have shown that as used as a second-line treatment, it's got 66% response rate in terminated status epilepticus. Okay, so I'm going to give you a case to have a look at. So this is a 38-year-old lady. She's got a left MCA infarct in 2018. She is witnessed by her husband to become suddenly unresponsive and just to sort of have a staring expression. She's brought in by the stroke pathway. She's seen 30 minutes later, and she's got twitching of the right hand and face with reduced responsiveness. She's intermittently able to vocalize and communicate with you. So, what is your diagnosis and what is your management? So number one, this is not status epilepticus. No intervention is required. Number two, this may be status, but an EEG is needed for confirmation. Number three, this is status epilepticus, but it should be treated as status epilepticus. Or number four, it's status, but it should not be treated as status epilepticus. Okay, let me just find out what you guys are thinking. Hopefully you can still hear me. So we've got options of 3, 1, 3. Give you a couple more minutes. Got 1. Okay, so got mostly for 3s and 1s there. Okay. So 1, this is not status, no intervention is required. Or 3, this is status, it should be treated for status. Okay, so if you were going to treat this patient, how would you treat it? 1 milligram lorazepam, 2 4 milligrams of lorazepam, 3 10 milligrams of buccal midazolam, 4 oral clobazam, or 5 IV levetiracetam. So we've got a lot of 2s here. Okay, so we've got IV lorazepam, 4 milligrams. Okay. Okay, so the main thing to know is, do we think that that episode was a generalized tonic-clonic seizure, or was it a focal seizure? Okay, so something has happened to this patient. She's got a previous brain injury. She's become unresponsive, and she's had a glazed or starey expression. And she's got focal signs. She's got right-sided twitching and right-sided facial jerking with reduced responsiveness. Okay, so from that description, it doesn't sound like this person has necessarily got a generalized tonic-clonic seizure. So the husband didn't see that she fell down, she went stiff, and she had bilateral jerking. Okay, and it was a witnessed event. So we've got fairly adequate information that we've not missed the onset and that this isn't a generalized tonic-clonic seizure. Okay, so what is it? So it is a motor seizure. She's got some motor manifestations. Okay, so this is the ILAE classification of status epilepticus, and it groups into 2 categories. We've got category A, where you have motor symptoms, and B, where you got without motor symptoms. Okay, so obviously convulsive seizures are going to go underneath that, but then obviously we've got focal motor seizures. So someone's got a focal right arm twitching or face, or someone's with myoclonus. And then those without anybody from, if they've got absent seizures and they're in an absent seizure for a very long time, or if they've got a focal seizure, very much like that temporal lobe epilepsy case that we saw from earlier on today. And if he was in that kind of absent, kind of focal impaired aware state for a very long time, then that would be in this column here. But what is the evidence? Do we treat these patients all the same and treat these all the same? Do we follow the status epilepticus guideline for all of these? Well, what they say is that patients, unlike tonic-clonic seizures, where we might get secondary neuronal injury after about 30 minutes, in focal status epilepticus, it seems to be a lot less dangerous. So that they can still self-terminate up to sort of maybe 10 minutes or so. And we don't think that secondary damage happens until maybe even after about 60 minutes. So the urgency to treat these patients is a lot less, because the risk of neuronal injury is a lot less. Okay. And so rather than treating them based on sort of their kind of classification, we should treat it by sort of almost a treatment approach. How do we go about it? So we've got stage 1 class evidence, i.e. those that follow the status epilepticus protocol, and those where we don't have any good evidence. And so all those where we don't have good evidence are probably the ones where we've got some focal motor seizure happening, i.e. they've got some like right arm jerking and right face jerking, etc. The myoclonic seizure is probably somewhere in the middle, but if they've just got sort of a bit of myoclonic jerks, it's probably less dangerous compared to a generalized tonic-clonic seizure. Now, non-convulsive status epilepticus, i.e. the subtle status epilepticus, that probably should be treated as a class 1, particularly if they've had a witnessed generalized convulsion to begin with, and then they've gone into that motor electrical dissociation. We'll treat that as a generalized tonic-clonic seizure, and we'll go down the status epilepticus protocol. If you didn't have a very clear history of a generalized tonic-clonic seizure, then you probably, but you're concerned that might be in that non-convulsive kind of status, or then we're probably going to treat them as a status epilepticus policy. But these other things are in this, that fall down into this category, they've got a lower risk of neuronal damage. And so we probably shouldn't be treating these as down the status epilepticus pathway, because there are risks of aggressive treatment, and that might not be justifiable for this group of patients. And then, of course, you've got people who have like acute confusional states who may have EEG abnormalities, but again, they will fall into this category. They are not patients that we're going to go down the generalized tonic-clonic seizure route. So non-convulsive status epilepticus, so that can vary. So that can vary from those who've really got like that temporal lobe seizure guy, and he's in a focal status. So that will be true non-convulsive status. Those with advanced convulsive status, i.e. the electromechanical dissociation, and then you've got some other syndromes that borderline in between it, okay? But true non-convulsive status, i.e. the focal impaired aware or the absences, like I said, there's no evidence that that's definitely going to lead to neuronal damage. And so those who have focal unaware or focal aware seizures and are in it for a very long time, because there's a low risk of neurological decline, we don't treat aggressively, particularly in the elderly, because they may be associated with worse outcomes. Those who have focal status epilepticus in patients who have an acute brain injury, are associated, they may be associated with outcomes, but we don't know if their aggressive treatment will actually improve that outcome. And because intensive care and anesthetic drugs are dangerous, so these are a couple of case studies that show that they have a high risk of mortality, infections, and longer hospitalizations. We don't necessarily want to put people in that scenario unless they really need to be there. So in patients who have sort of focal status epilepticus. So that lady that came in, she probably was in a focal motor seizure, i.e. she probably just had some right-sided face and arm jerking. She wasn't in the generalized tonic-clonic seizure. So in that case, what I probably would have done is either put an NG tube and give her some oral benzodiazepine, or directly go on to IV levetiracetam or valproate. And if that didn't work, then, and it still continued after 45 minutes to 60 minutes, give her one of the other two that I haven't given. Now, this is not so much something that we need to worry about. Absent status epilepticus, i.e. patients who have an absent seizure and they're in it for a very long time. That's a very small group of patients, but you probably could use oral benzodiazepine and again, valproate. But where possible, anyone who's got a focal seizure in the elderly would want to avoid IV benzodiazepine in that case, because the risks probably are not worth it in that population group. Of course, if they've got generalized tonic-clonic seizures and they've evolved into that motor electrical dissociation, then you want to treat as the status epilepticus protocol for sure. Okay, and this does not apply. Finally, a last case. So this is a 90-year-old female. She came in from a nursing home resident. She's got suspected respiratory infection. She's febrile. She's got CRP of 25. She's on oral antibiotics. The following day, she becomes drowsy. She's had a CT, non-puncture, they're unremarkable, and she's had an EEG done. And the EEG looks like this. So she's got some periodic changes to these. So, and the report says that there's evidence of global cortical dysfunction. She's got sharp and slow complexes that are asymmetrical, maximum on the right, and this may indicate a liability to seizures. The EEG could reflect a non-convulsive status epilepticus, but there's a periodic nature to these discharges, and therefore, depending on the clinical picture, you could raise the possibility of prion disorder. So what are you going to do? Are you going to give her valproate? Are you going to give her oral clobazam? Are you going to look at an MRI scan to see if she's got any DWI changes? Are you going to ignore the EEG? So what are you going to do? So I've got 1 vote for 4, got lots of votes for 4. Okay, right, so most people have voted for 4. Good, I'm glad to hear that. So that's exactly what you're going to do. You're going to ignore the EEG. Okay, so this patient's CRP the next day came back at 326, and she's got a sepsis-associated encephalopathy. Okay, and that can cause a lot of brain dysfunction, which we can see cause a lot of EEG changes, but that does not mean that that patient is in status epilepticus. So what she needed to be treated with was intravenous fluids and IV antibiotics. Good. So that is the end of my presentation. So hopefully you found that useful. I do sincerely apologise for my cough throughout that. Were there any questions? Okay, so how do you manage NEAD status for someone on the acute medical unit where the emergency buzzer is going off every half an hour on the night shift? Okay, fine. So in that scenario, what we need to do is, as soon as you've identified that as non-epileptic attack disorder, we need to sit with that patient and we need to explain what is, well, as long as they're they've come around, etc., and they're able to have a conversation with you, you want to discuss the diagnosis with them. So you want to tell them clearly you've had a non-epileptic attack disorder, and often the way that I describe that is that they've got a miscommunication between the brain and their body, and so that's causing them to shake and have involuntary movements. It's not something in their control, but it's not dangerous. And actually what you want to be doing is you want to be de-escalating the situation. So you should be educating the nurses that are around you that this is what her non-epileptic attack disorder seizures look like. And you should ask them to not press the emergency button, that when she has another one. You should get either like a support worker or nurse just to sit with her when she has that seizure, and you just want to provide reassurance. So you just want to, get her to hold her hands. Often a lot of these people do have some awareness, whether it's touch, whether it's hearing, etc. And you just want to give them reassurance. You're nice and safe. We're here with you. You're just having a seizure. It will subside in a moment. You do not want to be given any lorazepam for these patients. And I generally find that the more people that are around the beds, the more the more noise and attention that can often feed into sort of any anxieties that they have, and that can cause the seizures to continue. So I'd ask, so a good clear plan, i.e. make sure that the nurses don't press any more emergency buzzers, get a support worker to sit with them and to reassure them. Ideally, try and avoid doing repeat observations and oxygen saturations and oxygen masks, because that often it gets them worried, and so it's very hard to get in their mind that this isn't dangerous if you were applying that every time, because ideally what we want is to educate them and that these can be managed at home. And then basically the more and more that you reiterate that message, then these generally, they do settle down. Would I ever use placebo in NEAD? So no, we would never use placebo. I think often, as long as you're quite clear with the diagnosis and it's explained well, and that you give them support, often people don't feel as if they're validated when they have functional seizures. So they often feel, oh, it's not epilepsy, it's it doesn't matter, and then kind of left. So, but that so that often means that they feel like they are getting sort of what's the word, sort of shooed away kind of thing. So I think often if you tell them that you do have a problem, it's a functional seizure, it is very disabling, but it's not dangerous, so you don't need intravenous drugs or anything like that. Often they make you worse, not better, but we'll be here to support you. So just trying to reiterate that message is the most important thing. Speak out loud next to the thing. No, I definitely wouldn't say out loud, we'll be giving medications, can you give some saline? I definitely would not be doing that. The less interventions that you do, the much better it is. So ideally, just having a support worker there, a nurse with them, taking away the oxygen mask, taking away the observation machines, etc., and just allowing them to sit in a calm, relaxing environment is the best thing for them. In a suspected ASM toxicity, for example, if presented in EAU, how do you balance change in the dose, stopping the drug against the risk of causing seizures? At what level is it warranted for us to make drug changes in an acute setting, or should we always be under specialist review? I mean, if they come in with the anti-seizure medicine sort of toxicity, I mean, do you mean in the context of an overdose? Then probably what I would do is maybe just ask them just to miss a few doses, but then to go back onto them regularly after a period of time. It kind of depends on the situation. I think that's a bit of a difficult one to sort of explain in this context. I certainly wouldn't necessarily be reversing any of the anti-seizure medications. You could consider doing levels, etc. So you can see, like, for example, you can test for valproate, you can test for phenytoin. The other drugs like lamotrigine or levetiracetam take a very long time to come back, so that's not going to necessarily help you. So I think if they are overdosed on their medications, I guess you'll go on the tox base and see if there's anything specifically that you would need to do. But often you'd probably just wait, and then you'd probably go back onto their usual medications. But then obviously you'd have to treat the reason why they went into overdose in the first place. How do you balance? Is it warranted for us to make drug changes? So I guess in the A&E setting, what I'd probably want you to do is to check their compliance. Are they picking up their script from their GP? Are they physically taking their medication? That might be another reason why you'd want to do a level on them, like if they are on valproate or phenytoin, for example, because if they've got good amounts of level in their blood, then they're definitely taking it. If they're not and they've got poor compliance, then that's probably what I want you to reiterate. Just make sure you're taking their medication. If they came in and they were having lots of seizures, I probably would want to make a medication change. But if you're not confident in how to do that, then you can always call the on-call neurology registrar on call to help with that. Yeah, just to help sort of speed up the process. But yeah, if there was any clear trigger or if there's a mismedication or it's poor compliance, then I'll address those issues. I wouldn't expect you to be changing medications. Do we need to wait for EEG confirmation? All patients with non-convulsive status epilepticus before loading them with levetiracetam, particularly if there's no facility for in-house EEG or potentially a long time to happen. Yeah, so basically with that question, if there was in the history, there was quite a clear confirmation that that person's had a generalized tonic-clonic seizure. But now when you've seen them, they're not responding, they're not waking up, and they look like they're non-convulsive status, then they probably would go down the status epilepticus protocol. And you're right, in A&E or in AMU, you might not have the luxury of doing that EEG. So I probably would go down that avenue. Now, if it wasn't that clear history and it was like, a confused patient or, someone who's unwitnessed and, fall down the stairs and there's no obvious manifestation that they're any kind of like seizure activity, then I probably would get an EEG in that scenario. You need a little bit of a history at that point to help you gauge whether this could have been a seizure-like activity at that, somewhere in the ambulance they've had seizure activity or in A&E. By the time you've seen them in AMU, they're not waking, they're not responding. Yeah, so that there needs to be a bit of a history with regards to that. But if there's no clear history or they've just been, not been their usual self, they've been non-responsive for a couple of days and they've got lots of other things going on, then I probably would want to look for lots of other things and make sure there's not a metabolic dysfunction or an infective illness insult. And then, yeah, probably would wait for an EEG in that scenario. Okay, so how useful do you find lactate differentiating generalized tonic-clonic seizure in NEAD? Not very helpful. Patients with non-epileptic attack, as you can see in a lot of those videos that I've shown, have a lot of movements and muscle activity, so you can get a raised lactate with it. So I don't use that as my key feature to help differentiate between generalized tonic-clonic and NEAD. I think the best marker is, if you're looking at one, is the movements, because there's very classical movements that you can see in NEAD and very classical movements that you see in a generalized tonic-clonic seizure. So actually your history and what you're visually seeing when you're looking at that seizure are going to be your best diagnostic clues there. So that's what you're going to be depending on. And sometimes I ask patients can you take a video recording of your seizure, i.e. your friends or your family, if you're happy for them to do it, can you bring it in with you at your next appointment? Because sometimes, you can do as many EEGs as you like, they won't have a seizure in the EEG and it comes back normal. So often it's speaking to other people who've seen them and looking at videos is really where you're going to get your diagnosis from. Would you recommend prolactin in such testing for prolactin in such patients? So no, I've never really checked prolactin. Again, I don't find it very helpful. Again, I base it on my clinical assessment at the time. I'm looking at the patient's seizure activity and on the history. What is the most specific finding in differentiating a seizure from other events such as syncope or NEAD? I read it's the post-ictal phase. Other sources mention incontinence, lateral tongue biting. So hopefully I've addressed a lot of those questions already in this talk. But so if you're physically looking at an event, so the actual movement in the seizure that you see is what's going to help you differentiate it. And you can see that from a generalized tonic-clonic seizure to non-epileptic attack and syncope, that the movements for each of those 3 patients that we're making were very different. And so those hallmarks really are where your best clinical diagnosis is going to come from, is looking at those features. And again, for the syncope, it's going to be your history, and particularly what helps me is the prodrome, actually. So that classical feels sweaty, they're feeling hot, their vision's going dim, their hearing's going dim, and in your typical trigger, so like that venous section that we saw today, they were standing in a queue, it was already hot, they're feeling unwell that day, they had a cold or something like that, and they're on their feet. So that's what's going to help you. The post-ictal phase may or may not be helpful. So in some people, yes, it's very clear they've been asleep for hours and they've woken up with lateral tongue biting, urinary incontinence. That is all supportive. But it's not uncommon for patients with non-epileptic attack to say that it took me ages to come round. We were 30 minutes, an hour. And, you know, when you try and get down to the gritty details, it's very difficult to find out if they were really asleep or conscious or they were like in that scenario. Lateral tongue biting I do find quite specific for epileptic seizures, but you know, but non-epileptic patients do say that they can bite their tongue. Typically, it's mostly the tip, but really, if you see it, that's really helpful. So it's more the motor manifestations again and the history that's helping you to make those diagnoses. I think you have to take prolactin during the seizure or immediately after. Yes, so prolactin is usually at the time of the seizure, but I don't see very many people doing that. I never really did that when I was on the wards or when I was in A&E. So I don't think it's something that's routinely used. And I don't find that particularly helpful. So I wouldn't be basing my diagnosis of non-epileptic attack or generalized tonic-clonic seizure based on a prolactin level. I'll be basing it on the history and if I happen to see the seizure, what it looked like. Good. Any other questions for me? And hopefully I've helped that's cleared out some of the issues. Okay, fantastic. Okay, so I think we'll leave it there. I did go a little bit over time. I do apologise, but I did want to answer some of your questions. Great, thank you very much. Dan, I don't know if you wanted to say anything else.
No, that's great. Thanks very much for that, and thanks everyone for coming.
There was just one question, how would an EEG be helpful if it's not during a seizure? Well, it might not be helpful actually. So in between seizures, whether it's an epileptic or non-epileptic attack disorder, EEGs can look very normal. So it might not be helpful. In some patients with epilepsy, they might, particularly if you sleep deprive them, have a little bit of an inter-epileptic form activity, but it's not in everybody. And so really to clinch the diagnosis, it'll be the history, seeing a seizure and getting a description from the patient or their relative. All right. Thank you very much. Bye-bye.